you're an N of one in this situation, meaning we don't have anybody else to compare you to. So let's see how far we get, but let's do as much as we can to understand why you are having symptoms, how we can control your symptoms, how we can get you as active as possible, understanding what your expectations and your life demands are. You're listening to the Active Mom Podcast with host Dr. Carrie Pagliano. I'm a mom, physical therapist, and your go-to guide for staying active with pelvic health issues in pregnancy, postpartum, perimenopause, and beyond. Whether you're a fellow mom, physical therapist, or women's health professional, join me where I'll share expert insights, real-life stories, and the latest research to help you approach running, CrossFit, yoga, Pilates, HIIT, or whatever activity you love with confidence and evidence-informed guidance. Let's start the show. All right, welcome to the Active Mom Podcast. We're going to do a quick little mini solo episode today. It was inspired by some requests recently of new moms that are less than 6 weeks postpartum, and they're experiencing heaviness in the pelvic floor. And I think anytime you're experiencing symptoms past the first couple of weeks, because that first couple of weeks you are drinking from the fire hose and Niagara Falls kind of all at the same time. Once you start kind of experiencing that, it sends a lot of kind of questions into your brain. It's scary. You start Googling, you see the pictures, you're like, wait, heaviness, pressure, prolapse, what the heck is that? So I thought we'd just do a quick, I think I have prolapse, what the heck's going on episode. And I think what's even more troubling is, let's say you go in and do that 2 to 3 week postpartum visit, if you're lucky enough to have it, and your provider's like, don't worry about it. That's just what happens, and doesn't refer you to early postpartum physical therapy. And that's one of the main reasons that I want to see that patient sooner than later, is because there are things that we can do that early. And this idea that doing nothing that first 6 weeks is honestly setting our patients up to be deconditioned. It's delayed access to care. When you have something that you're not sure what's going on and it's not getting any better, I think that really screws with your head a little bit and sets us up for some additional issues that could compound or make postpartum depression worse. So that's why I want to talk about it. Let's start from the beginning here of what causes prolapse. And from the data that is out there, from the research that is out there, we don't have 100% definition, but essentially what we call prolapse is that typically that feeling of heaviness, pressure in the pelvic region, typically associated with vaginal childbirth. You can, of course, have prolapse with a C-section. Some other things that people who aren't postpartum can experience, those symptoms, heavy lifting, chronic constipation, those sorts of things. Those are also risk factors that we'll ask about. But typically it's, we have a combination of factors during birth injuries, quick births, big babies. I know sometimes people are like, I only pushed a couple times, but if that baby comes hard and fast, those tissues don't have time to prepare, especially first time around. Certain interventions, forceps, vacuum extraction, we can get damage to the pelvic support structures. So I think that's probably the first poignant point, is when you Google, you're like, the organs are falling out. That's actually not true. We have lack of support, or there's some sort of injury to pelvic support structures, which might include fascia. Fascia is that kind of almost like pseudo clear saran wrap material that you find on the outside of your chicken breast. Well, that's between your organs. It's overlaying on all your muscles. It plays a really, really important role in support in the pelvic region. We have ligaments. Ligaments are bone to bone. There's a lot of those in the pelvic region. And then we also have tendons, and tendons are muscle to bone. And then there's the muscle. So we have all these support structures that, yes, they've been influenced by hormones to get a little bit more lax, get loose, get out of the way during childbirth. But sometimes positioning of the baby, difficulty relaxing the pelvic floor. There can be genetic factors. We now are understanding that a certain percentage of the population, there can be a genetic kind of disposition for prolapse. We think that these are some of the reasons why we have moms that may have birth injuries resulting in damage to these structures. And then what happens is we have, if the structures aren't supporting the organs, then we have kind of defects to the vaginal wall. So think about the vaginal wall as kind of this tube, and then kind of surrounding on either side of the tube, you've got the bladder that might kind of play into the, kind of lean into the vaginal wall. You've got the uterus and the cervix that might drop down a little bit. We've got the rectum that kind of might lean into the posterior vaginal wall and not be able to support that. And so essentially what we see, if you look, is what you think is the organ, but it's actually, an underlying defect or injury to the support structures. And then that organ is kind of playing into that laxity or that damage or that injury. And so I think for a very long time, like our grandmothers, they didn't talk about it because they didn't know what to do. But historically, we hear about pessary supports, like, hey, just stuff something up in there like a sponge or whatever. Our grandmothers just shoved it back in because we didn't know to do anything about it. But again, you can have, and I've talked about this before, you can have anatomical prolapse, meaning, yes, we've got injuries to these structures, we've got descent of the organs into the vaginal walls, and no symptoms whatsoever, and you're not even aware of it. Or you might feel heaviness or pressure. One of the stories I tell all the time is I had this client years ago, this was probably 15, 20 years ago. And she's telling me her story. She's probably in her 60s, 70s, don't think too much of it. And then I go to lift up the sheet for the vaginal muscle assessment, and it's literally like a rutabaga sitting on the table that her rectum had come out. She's like, oh, I just stuff it back in and, no big deal. That is a surgical case. That is not something that I can navigate. Yes, we can talk about pressure management, not straining and kind of all this other stuff, but like I can't fix that. And I think that kind of brings us to the next question of, okay, this is what it is. The two questions that ultimately follow is, one, is there something that I could have done to prevent it? And two, how do I fix it? And those are very nuanced questions that I think when you're first starting down the prolapse rabbit hole, there's a lot of self-blame that you did this to yourself. And I think that with the fix question, it's very black and white, and you don't want to hear anything other than, yes, I can fix it, or no, I cannot. And let me preface this conversation, one, by saying, I've worked with prolapse for 25 years. Two, I have my own prolapses that I have navigated, a mild rectocele and a little bit of cystocele, which is the bladder. You can also have a little bit of urethral hypermobility, meaning the urethra doesn't have as much stability, and then also uterine prolapse where it's dropping down. You can have any combination of all of them. So I come at it from a sense of knowing, I guess, and understanding that of all the birth injuries you can have, this is the one that probably has the most fear to it. It's probably the one that has the most kind of mental health implications, because the idea of your organ being somewhere other than where it's supposed to be is scary. But I think it's also, this idea that is in our head about what those organs are is typically that health class cross section from like middle school. And in your head, it's very static. Things are supposed to be in a certain place. When in actuality, it's a very dynamic neighborhood. Like everybody's contained within the pelvis, but we have this kind of like symbiotic relationship. Like when the bladder is full of urine, some things are going to move out of the way a little bit. When the rectum is full of stool, some things are going to move out of the way a little bit. When your uterus has a baby in it, a lot of things got to get out of the way. So it's not this set in stone concrete cross section. It's a very dynamic neighborhood, and everybody has their space and place and accommodates everybody else. But when you have it's almost like between you and your neighbor. If you have a fence and the fence kind of keeps everything in, and it's, the fence moves a little bit, but like it's a fence, right? And with birth injuries, maybe there's a break in the fence, like a partial, like maybe one of the slats of the fence is partially broken. And so that the dog jumps over next door or something like that. Or sometimes you can have a full um, thickness damage or what we call an avulsion or a tear of the muscle away from the bone. And part of the issue with a lot of these things too is that one, we didn't have the imaging to be able to diagnose it. We're getting better at having more people that are skilled enough because there's not the anatomy is really different. There's a lot of overlay and blending of tissues into each other. It's not clearly delineated. Like, your bicep is really clear. If you look at an anatomy book, it's super clear. Pelvic area, everything kind of meshes into everything else, which is beautiful. Like, I did a fresh cadaver dissection a couple of years ago, and it's just glistening and pearlescent where the ligaments and the fascia are, and the muscles are just bright red, and just it's gorgeous. I've done some preserved pelvic floor dissections before, and it's a lot duller. But again, both of those, you get a sense of the intricacies and the three-dimensionality of the area. And I think we're just starting to get a better understanding of what that is through imaging. But then also, okay, once you see something, do you know what to do with it? And we don't have any surgeries yet. We did do a podcast recently with Dr. Imran Siddiqui, who's doing platelet rich plasma treatment, so PRP, to help improve injuries and partial tears, things like that. But again, the first thing is you have to understand it. And then the second thing is, okay, now that I can see it and I can understand it, what can I do with it? So anyway, so we're getting better kind of like, hey, this is kind of why these things are happening is it's actually the support structure. It's not that there's a problem with the organ, but with the support structure. And so the symptoms we typically get, again, are heaviness, pressure. And sometimes people look and they see something coming out, which is super scary. So again, the mental health piece of it. A lot of people didn't look before they got pregnant. And so things might have looked a little weird before then. The other nuance, as we're talking about nuances, that's tricky here is the staging. So historically, the medical literature, the gynecological literature, has staged prolapse severity, one being a little bit of descent, two being at the opening, 3 and 4 being kind of outside the perineum. There is some data to suggest that this grading system might actually not be great, that a 1 and 2 might actually be, quote, normal in nulliparous females or women who have not had kids yet. To me, that says, can we start over and make a new grading system? Or can we be a lot clearer on what norms are? Because you get these moms that feel heaviness or pressure, or they didn't know anything about it. And then all of a sudden somebody says, oh, you have a grade 1, cystocele. And they Google and they didn't have symptoms. And all of a sudden they do, because that happens all the time. I'm not even kidding. And again, that goes back to, you can have anatomical prolapse and no symptoms. You can have no anatomical prolapse and totally have those symptoms. So you can have this kind of dichotomy. It's not just one presentation. And so the nuance is, we need to be very careful about the information that we provide and what that means to the patient. If the patient does not understand that a 1 can be totally normal and they might have had it before, then it doesn't really matter. But to them, if they see 1 cystocele, oh my gosh, that's dysfunctional or that's bad. Now all of a sudden, things can definitely get worse. So there's a lot of nuance associated with this diagnosis. It's probably, again, one of the hardest to have to navigate holistically because you're having to deal with a lot of kind of parts and pieces. All right, there's this stereotype that all you need to address prolapse is, oh, I just need to strengthen my pelvic floor muscles. And in some cases that might be true because, if you have damage to other structures, the pelvic floor might provide a good support. Sometimes what we do see though is muscles that actually need to improve tone. So their tone is too high. So they're protecting, they're supporting. And sometimes that can be, adjacent to a birth injury. And they actually need to relax those structures and improve coordination and then build strength. So this idea that there's only one way to treat the pelvic floor of somebody with pelvic organ prolapse and that's strengthening. That isn't necessarily true. In some cases, what we need to do is actually down train because there's a hypersensitivity, or this is what we perceive, whether, I think we'll figure this out later. But the down training appears to decrease sensitivity and then gradually increase graded exposure to activities that might give symptoms. And that's, again, another nuance in this. Sorry, this is, we just should just turn this into the nuance episode regarding prolapse, is that you shouldn't have any symptoms at all. And sometimes that's really hard to progress. So historically, for a long time, we're like, don't do anything that makes your symptoms worse. But then you're doing nothing. And what if that includes taking care of your baby and so on? And so we've kind of, at least I have taken a lot of what I've learned about getting back to activity and chronic pelvic pain and kind of getting your brain on board and not protecting as much anymore and decreasing that sensitivity by using guardrails. So I use symptom guardrails, like figure out what your baseline is. Let's say you can walk for, 2 blocks. And while you're walking, your symptoms are 3 out of 10. Great. All right. If you're going to increase, say we're going to go another block. I don't want your symptoms to increase more than 1 or 2 out of 10 more than where you started. So we're not expecting you to start at 0. If your baseline is 2, no more than a 3 or 4. And then I don't want those symptoms to last longer than an hour afterwards. And I sure as heck don't want them to go into the next day. Okay. And if they do, that doesn't mean that you did anything wrong. That just means that we need to tweak our dosage. And it was just too much for your body to kind of navigate. And again, it doesn't mean that you messed up and you can make this worse. It just means that we need to be a little bit more gradual in exposure. So that kind of brings about the question, can I make things worse? And that comes up a lot. And that's kind of the intermediate question on, how did this happen? Was there anything I could do to prevent it? And, how do you fix it? Typically, to go back to, is there anything I could do to prevent it? I think it depends. If you have a chronic history of bearing down and, things like that, maybe. If your mom had prolapse, then probably not. So again, conversations you need to have at Thanksgiving dinner. Or before then, hey mom, did you have prolapse? Do you have prolapse? To see, because you can't prevent your parents. Sorry. So the short answer on the prevention is, we don't know. Maybe, maybe not. The intermediate question on, can I make this worse by doing stuff? And this is, again, we don't have data to say yes or no, but what I can tell you is look at what got the diagnosis in the first place. Maybe it was, big baby came out super fast. Okay. Unless you're planning on doing that anytime soon. And again, that's a bigger question for later when we talk about subsequent pregnancies. But it's typically a pretty big thing that got you in that situation. So taking a walk around the block is not going to make things, quote, anatomically worse. And I think that gets mixed up with your symptoms feel a little bit worse. And again, that's where we're going to use those guardrails of like, okay, it's okay to feel something as long as it comes back and feels better. Like it's okay to kind of bump up a little bit. And then, we want to undershoot, but sometimes we might overshoot. Don't overshoot too much because again, that's going to kind of increase the catastrophizing and all of that. So generally I tell people, no, there's really not anything you're going to do on a day-to-day basis to make it worse. And then the question about fix. Fix to me implies a lot of things. Fix as in, yes, I want to get you back to doing all the activities that you want to do without symptoms. Yeah, that's the plan. Anatomically fix, that might not be the goal, nor we might not need it to be. Now, yes, if there is a tear, if there's a avulsion, if there's structural damage, some of that, especially in that first couple months to a year, we want to support that healing as much as possible. And yes, we are looking at things like PRP to try and it's regenerative to try and kind of increase healing in those areas. But again, anatomical fix may not be the goal, but in my mind, fix means get you so that you have as little symptoms as possible and you're functioning the way that you did previously. And that again freaks people out because they think, okay, well, I can't do what I want to do unless I'm anatomically the same as I was before. Regardless of whether you have prolapse or not, you're not going to anatomically be the same after having a kid. It's just biology. Same thing with age. I'm not anatomically the same as I was 2 years ago or even yesterday. Like that's just kind of how things are. And that's not a bad thing either. So a lot of these nuances too kind of go back to what are our preconceptions about our bodies and how they change and what happens in childbirth and our expectations. And then how does that compare to actually what's going on? And do we really need to kind of update our understanding of what our body does and then compare it to what our expectations were, which might not have been realistic in the first place. So, all right. So that answers the preventative, can I break it, fix question. I think then the next part becomes, okay, well, now what do we do? And I want to see that patient as soon as possible to get them started doing core exercises, anything that we can do, breathing techniques, pressure management techniques, anything to reduce symptoms as much as possible. Sometimes external supports. There's a lot of external garments out there now. SRC shorts, I think Hem has one, MyPFM, pelvic bra. There's a lot of external supports that can be helpful for some people. And then the goal later on, we might pursue an internal support like a pessary. And we're looking at using those earlier in postpartum once those vaginal tissues have acutely healed and the tissue's good integrity. We might need to get a prescription for local topical vaginal estrogen because we're in a lower estrogen state. To get fit for a pessary so that it's almost like an orthotic. So take the pressure off and then allow those structures to heal in a little bit better, where they're not having to navigate force at the same time. So these are all the considerations that we're looking at for those first couple of visits. And I get a question a lot, and it's very, very motivated people. Like, you gave me these exercises to do once a day. If I do them twice a day, will I get better faster? And this one, like, I have to take a step, like a second before I answer it, because there's a couple things that occur with that first exercise prescription. One is I'm looking, is the dosing right? So the things that I give you, is it increasing your symptoms? And if it is, we need to figure that part out first before I give you more. So when I give an exercise prescription, initially, I really expect people to follow it. And I expect them, well, I would hope that they would understand that it's given with intentionality and purpose. And that first one, again, we're just looking for baseline, is what can I give you that's going to undershoot your symptoms and allow us to start to build that coordination, timing, maybe a little bit of strength, get you a little bit more active, kind of mental health wise, like you're doing something, feeling good. Same thing with walking. I don't want to overdose and make you, feel awful. I want to figure out what can I have you do that's not going to increase your symptoms, or if it does, it's not going to be any more than that 1 or 2 out of 10, and you're going to come back pretty quickly. So especially when people are first starting, I'm like, whatever I give you, I need you to follow like it's written in stone. Because if you start going and changing these things on your own, you're adding variables that I did not account for, nor did I plan or intend for you to do. So be really good about following people's, therapist first directions. And I always tell people, I'm like, if you have a question, if you're like, hey, well, what about this? What about this? Ask me and I will tell you why. And I think this is the hard part. This is the thing that I don't think about anymore, having done this for 25 years. And this is kind of exercise and in general, is that it's almost, this is our version of giving you a prescription for medicine, is dosing exercise. And would you go to your physician? Like I take high blood pressure medication. Would you go to your physician and be like, well, if I take 2, will it make my blood pressure go down faster? I don't even ask that question because I'm assuming that the dosage they give me is supposed to do the thing that I want it to do. But we don't look at exercise like that. We're like, all right, well, if I do twice as much, will it make me better? And that's where, again, like, there's a whole lot of other things wrapped up in that. The short answer is no. It will not make you better faster. It can make you worse. Meaning if we flare your symptoms, now all of a sudden, now you're going to be scared. Now you're not going to want to move. It's going to make my job harder. It's going to make this process harder for you and longer. It's not going to make your prolapse worse, but it's going to make you feel worse if we don't dose that right off the bat, or if you're not following my dosing recommendations. follow your therapist recommendations. We could do a whole podcast on that. A lot of the things that we'll use are breast strategies to help manage transitions, sit to stand, getting in out of bed, picking up babies. I'm really lucky here that I have real-time ultrasound. So we will find the exact cue that gives us transverse abdominal activation and proper timing, pelvic floor activation and proper timing. I can give really specific recommendations. And then if they're like, hey, I want to take this class or I want to do this video, I'm like, great. Well, when they tell you to breathe or when they cue this or before you do this movement, you're going to use your strategy that you learned in here and overlay it onto that program. Okay. And so that's a really cool thing that we can be really specific about. If you don't have that as a provider, you can give general recommendations on kind of generally what works and then monitor symptoms. If the strategy is making symptoms worse, then we need to tweak the strategy. Okay. Other questions that I get, how long is this going to take? And after a first visit, I don't know. I think what moms don't want to hear, which is actually the truth, whether you have prolapse or not, is you're probably not going to feel like yourself for over a year. This is aside from pelvic floor issues. Like this is just first time mom in general. And I don't think anyone with older kids is going to disagree with me. And if you do, I would love to chat. Like there's just so much crap. Okay. As far as prolapse is concerned, again, the sooner we can get on calming the nervous system, decreasing those symptoms and getting moms active to then they can start to build up strength and be more themselves. And there can be a lot of different ways we can do that. Exercise, pessaries, support shorts, whatnot. Once we start doing that, then mom can start to feel like herself again. And then, but there's a couple timelines that we can't make faster. So general soft tissue healing, we're at like 75% by 6 weeks, full soft tissue healing by 12 weeks, but there continues to be changes that go on in that first year. I cannot make that faster. So we have to kind of go with that tissue timeline. Okay. Other things come up too, like baby might be sick, baby might have had tongue tie surgery, baby might have reflux. Like this is the hard part in postpartum is like, yeah, I need you to eat well. I need you to sleep. I need you to have low stress. And that's just not those first weeks and months of postpartum. And so sometimes things are a little slow at first. But I tell people, like, if you've had a sports injury, if you had a surgery prior, it's a gradual return back to baseline and then building up from there. But understanding that it's not just about the birth, you probably were deconditioned. Even if you worked out during pregnancy, you got deconditioned over those 9 months. And so we're also trying to build back from that too. So, now how much of this I say on the first visit is really hard. I'm not going to lie, because mom's already drinking from the fire hose. And then if I, lay all this on her, she's gonna be like, bah, deer in headlights. And so I have found like I have to be as positive as possible, but also being careful how many kind of truth bombs that I throw at the same time that they might not be ready for right off the bat, but providing as much support and good vetted resources as possible and hope and, whatnot. And because again, a good number of patients do really well if they have early symptoms and get early intervention, and they're going to do fine. And then there's a small, group of people that might have birth injuries where they truly did have damage or avulsion or something like that, we don't know how far you're going to get. And no, anatomically, there's not a lot we can do to fix it. Maybe PRP, that's still really new in the last couple of years. It's out of pocket. Like there's a lot of things. And so I try and be as supportive as like, you're an N of one in this situation, meaning we don't have anybody else to compare you to. So let's see how far we get, but let's do as much as we can to understand why you are having symptoms, how we can control your symptoms, how we can get you as active as possible, understanding what your expectations and your life demands are. And that individual approach, I find both mentally and physically is the best one, because once you start playing the comparison game, it's awful. It's not great. And it's not fair either. It's not fair either. That, I think that's like intro to prolapse in a nutshell. It's one of the most challenging things in postpartum as a pelvic floor PT to treat. I think it's also one of the areas where we have the most opportunities for growth and increase in research and changes in how we treat it clinically over the last, several years. I certainly, because I've had my own experiences, I certainly understand the mental toll, especially for active moms who want to lift and run. And then unfortunately, when you Google, you're like, oh, lifting's bad for prolapse. No, the data that they're referencing is occupational health, meaning, nurses or whoever who are lifting patients in hospitals. And that's very different than conscientious, barbell lifting or kettlebells or, lifting for strengthening reasons. And, as far as, running goes, we haven't done the research, and, we have more opportunities than ever to kind of understand pregnancy, postpartum running and what happens in the pelvic floor and how we can support it better and how we can transition to get back to higher level and impact activities. There's more potential now than there ever has been in my entire career of 25, 26 years. So I'm incredibly hopeful. Hopefully, if you have prolapse and you're listening to this, you have a lot of questions. If you don't have a pelvic floor PT on speed dial or somebody local, definitely hop in my DMs, email me, carriepagliano.com. Happy to answer any questions or point you in the direction to resources that are local to you. Happy to do that, especially those of you that are trying to get back to lifting, running, that sort of thing. And if you're fresh, because again, I think that's where we lose a lot of people is they get scared and then stop moving. And you don't need to. We just need better management up front. So have any questions, definitely hop in my inbox, shoot me a DM, say, hey, I listened to the podcast. I got some questions, because I find that it's easier to answer those questions before you go down the rabbit hole. Because once you've gone down the Google rabbit hole, then I have to unpack and tell you why all that stuff is wrong and why this is a far more hopeful process than you might think. So hopefully this helps. Send me your questions. Otherwise, I'll see you on the next episode of the Active Mom podcast, and hope you enjoyed this episode. If you're navigating pregnancy, postpartum, or perimenopause, whether personally or professionally, check out all our free resources and upcoming courses at carriepagliano.com. This podcast reflects the opinions of Dr. Carrie Pagliano and her guests, and it is for entertainment purposes only and should not be considered medical advice. Always consult your healthcare provider with any medical questions. If you enjoyed the episode, please take a moment to leave us a 5-star review on your favorite podcast platform. And thanks for listening.